Hello everybody, and thank you for taking time out of your evening tonight to join us online. We're very excited to have you. My name is Eloise, and I'm one of the primary care engagement officers here in Townsville. The webinar tonight is being recorded. You will notice that on the top of your screen. To start off, I would like to acknowledge the Aboriginal and Torres Strait Islander peoples as Australia's First Nation peoples and the traditional custodians of this land. We respect their continued cultural and spiritual connection to country, waters, kin, and community. We also pay our respects to their elders past, present, and emerging. So tonight we are very privileged to be joined by Sarah Drew from APNA. Sarah is an experienced registered nurse with an extensive background in primary healthcare, immunisation, chronic disease management, and IPC nursing. For the past 17 years of her career, Sarah has worked in a variety of leadership, management, educator, and clinical roles within primary health networks and education to support the PHC workforce. Sarah joined APNA in June of 2021 as the Nurse Programs Manager and Victorian IPC Helpline Manager. Sarah's passion is supporting and strengthening the role of PHC nurses through workforce development and education, and raising the profile of PHC nursing with undergraduate nurses. Sarah is an accredited nurse immuniser with a strong interest in public health. I'll hand you over to Sarah to start the presentation.
Thanks for that, Eloise. Wow, that's a mouthful, all of that. So thanks for going through it all. So welcome tonight, everyone. And if we've got anyone that joined us at one of the three live sites last week, hopefully, you'll pick up a few more things tonight. But just to start off tonight, really the intent of what we're going to do, as you can see on the screen here, there is a lot to cover in the couple of hours. And even all last week, I tried to get through it in an hour and a half. It's a bit of a push, but just so that we've got some time afterwards for some Q&A. So let's see how we go. If you do get any questions, happy for you to put them in the chat so that, you don't lose it, and we can come back to them at the end. So what we're going to cover tonight is we're just going to talk through what the intentions of the IPC guidelines are and, the process that we went through reviewing them and the development. We're going to discuss the IPC requirements for accreditation as per standards for general practice and the role that the guidelines have in actually supporting practices and office-based organisations to meet those. We're going to review, some of the training that's required for an IPC coordinator. And then what I want to try and do is briefly take you through each of the sections of the guidelines. There's 12 sections, and just point out, anything that might be newly added, but also some of the key supporting aspects in each of those. So just to get us started, I always like to start with this upside down pyramid. And the reason I do this is not all organisations are accredited, okay, against the RACGP standards, or it might be, one of the other peak bodies standards. In saying that, though, even if you are not an accredited, for instance, general practice, you still have to abide by the Australian Commission on Safety and Quality in Healthcare's standards, of which in there is a handful of IPC standards. So next down under those standards comes the Australian and New Zealand standards. And the one that's currently under review that everyone's pretty much aware of is the reprocessing standards. And so they sit there, there's cleaning standards, there's a whole heap of others. So all of these Australian and New Zealand standards override anything we have in our accreditation standards. And you'll notice in the accreditation standards that they are word for word what is required. So next layer down, we have our accreditation standards. So for those in general practice, it's the RACGP 5th edition standard. There is, like I said, there's the NSQHS standards or there's the QIC standard. So it just depends on what office-based type organisation you're in. Then we have what we're going to unpack tonight, and that's the IPC guidelines for general practice, office and community-based practice. And that's the document that used to be called the IPC standards for general practice, office and community-based practice. And I'll talk to you a little bit as to why when we did the review, we actually changed the name. Then once we've got all that in hand, we've then got to consider our specific state and territory guidelines. And let me reassure you, every state and territory in Australia, thank goodness for Federation, has some slight different guidelines when it comes to different things. So some of that's like clinical waste. And so you need to make sure that you're aware of those. Then we take all of that and we create our infection prevention and control manual, of which inside that manual sits all our policies and procedures for everything that we're going to discuss tonight. So to get us started, let's just have a really quick Cook's tour of where you'll find IPC in the RACGP standards for general practice. So principally, the standards refer to IPC in criterion GP 4.1, which requires a practice to have an infection prevention and control coordinator, to have written policies on infection prevention and control, to ensure that all practice staff manage risks related to IPC, and to ensure that patients are informed about all aspects of IPC relevant to them. And so if you think about that, what's relevant to a patient? Well, it's things like cough etiquette, hand hygiene, okay? Notifying if they think they've got an infectious disease. So those sorts of things sit within that. So the infection prevention and control standards, like I said, also, did I skip a slide? No, there it is. So you'll see here that if we talk around the standards, that this is where they will principally, you'll find all the different areas, okay? So infection prevention and control, a practice infection prevention and control policy may form part of your emergency response plan. And so that's under C3.3 or criterion C3.3, which is your emergency response plan. Under criterion C8.1, we talk around education and training of non-clinical staff. And so we need to make sure that those staff complete training appropriate to their role and your patient population, which may include IPC. And of course, the obvious one that comes to mind there is things like blood and body spills, okay? So they may need to clean up a spill. And so the next one that we have is criterion QI 3.1, and that talks about managing clinical risks. And so that's having systems and processes in place to support IPC that helps to identify, implement, and test solutions to prevent near misses or adverse events. Then under criterion GP 1.1, we need to have a responsive system for patient care. So we need to make sure that our IPC policy contributes to the effective triage and consultation types that meet our patients' needs. Under GP 1.2, which talks around managing home and other visits, we need to make sure that our IPC policy contributes to a safe provision of home and other visits. That's one that quite often gets missed. And then criterion GP 5.1 looks at when we're setting up and maintaining our practice facilities. As a practice, you must consider the principles of IPC when doing that. And then GP 5.3, the good old doctor's bag that actually gets left in the boot of the car when we're all going through our survey visits. But we need to make sure that the equipment in the doctor's bag is dictated by the principles of IPC and control. And so you'll see here that the requirements for accreditation in the standards haven't actually changed in the process of us updating the guidelines. However, the details in the IPC guidelines informs that what information, processes, policies, and so on that you as a practice needs to cover to actually meet these indicators that I've just pointed out. There's actually some fairly strong language also that we use throughout the IPC guidelines. And it's a dead giveaway, to be honest, as to what you will need to really take note of. And so whether it be an accreditation standard, a national standard, or other legislation, it is very clear. And so you'll hear me say tonight things like could. So when I refer to a could in the IPC guidelines, it means that we use that to indicate that something is actually optional. If you hear a should, It's used to indicate that something is strongly recommended by the RACGP and key sources from which the guidelines have been drawn. And then the big one is the must. And the must states that you must, as it says, indicate, when we use must, it indicates that something is mandatory. So you must have that in place no matter what. So let's have a look at the guidelines now. Let's break down each of the 12 sections. And I'm going to provide you, like I said at the start, with an overview of the content in each of the chapters. And while we absolutely don't have the time tonight to go through an exhaustive overview, I'm hoping that it'll support you in orientating you to the newly released guidelines. And what I want to do is sort of take each section and just cover them broadly. I'm going to highlight to you some of the pertinent information that's been added to sections based on existing requirements, such as the national guidelines or the Australian standards. And I'm going to point out for you some key resources that are contained in each section, because the one thing you don't need to do is reinvent the wheel. Yeah, it's all here for you. So on the screen here, you'll see this first document, the Infection Prevention and Control Guidelines. That is now what the guidelines look like. So hopefully everyone's had a chance to sort of have a look at those, has seen, some of the advertising that's come out over the past sort of 6 to 8 months. But these guidelines were developed throughout 2022 by the RACGP Technical Working Group, of which I did sit on that group, for infection prevention and control. And it was funded as expected by the Department of Health and Aged Care. And the working group included experts from fields of infectious diseases, microbiology, infection prevention and control, as well as a couple of doctors, the most nurses that I've ever seen sit on a working group, and one practice manager. The standards were initially mapped against the Australian Guidelines for Prevention and Control of Infection in Healthcare, which was most recently updated to actually reflect the lessons that we learned through COVID-19. And then the drafts were reviewed and contributed to by us, the working group, but also a wider group of nurses from APNA, the Department of Health and Aged Care, and the RACGP Committee of Standards for General Practice. And ultimately, at the end of the day, they're the ones that had to endorse the resource. We made the decision to change the name from a standard to a guideline to better reflect the resource's purpose, as it's designed to provide support to practices in meeting infection prevention control requirements, and is not in itself something that you as practices will be accredited against. And then, as you can see on the screen there's a number of resources that we actually drew the guidelines from to make sure that they were all aligned. So what's the purpose of the guidelines? So the guidelines were intended to help health professionals in office-based practice implement IPC procedures. So practices, like I've said, aren't accredited against the IPC guidelines, but they may refer to them to support them in meeting the relevant criteria of the standards. So they're the 5th edition standards that we're currently working with. And it's important to note that while wholesale changes weren't made when updating the IPC standards to guidelines, the updated guidelines do not implement new requirements that are not already in place via the Standards for General Practice, the Australian standards and the Australian New Zealand standards, or the national guidelines, or any other national or jurisdictional legislation that currently exists. The update, in fact, consolidated and contextualised advice from those sources specific for general practice and other office-based practices. And we've added additional detail for practices throughout the guidelines to help you meet existing requirements. So when we released these guidelines in November last year, the Victorian helpline just about blew up because people just went into a panic thinking these were all new guidelines. I can assure you, absolutely nothing has changed in them. We know there's change coming in regards to reprocessing, but at this point, nothing's changed. And so, in fact, what it highlighted was that practices weren't, in fact, meeting the standards. Okay, so the guidelines have also been developed as a web-based resource. So for those of you that have been around for a while, you'll know that, in fact, it's not a printed document anymore. It's not one that you purchase, but in fact, we have it as a HTML because it is interactive, and that way you can download or click on links. In saying that, I think we've already updated the guidelines about 4 times since we released it, just, with emerging evidence that's coming out. So it's really, really critical. It's like when we had the hard copy of the Australian Immunisation Handbook. The second these things are printed, they're out of date. So this is why. So download this and have it as a shortcut on your computers in your workplaces. So what's in the guidelines? So the guidelines address the basics of infection prevention and control in section 1, and that's where we talk about the basic principles, hand hygiene, PPE, equipment, aseptic technique, and the levels of protection. And we're going to go through all of these. Section 6 to 8 talks about managing staff risks, and that's things like staff screening, immunisation and infection management, sharps and exposure to blood and other bodily substances. Section 9, we talk around cleaning, laundry and waste management, so managing your practice environment. Section 10 is a whole section on itself and took us forever to finalise, but it's around reprocessing of reusable medical devices, so managing your equipment. And then managing outbreaks is section 11, so everything to do with disease surveillance and outbreak response. And aren't we good at that now? And then the last section, which is around practice setup, section 12, talks around practice design, fit out, equipment and consumables. And we talk around air exchanges there, ventilation, those sorts of things. So let's break these down for you. So transmission of infection in healthcare. So the IPC guidelines acknowledge very much so that there's emerging literature that understands that transmission through the air applies to a continuum. However, the language regarding modes of transmission is consistent with what the current national guidelines state. In healthcare settings, pathogenic microorganisms are acquired mainly through contact, droplet, or airborne transmission. Contact is the common mode of transmission is the most common mode of transmission in healthcare, and that's usually via touch or contact with blood or body substances. And I don't think that's anything new to anyone. We also know that droplet and airborne transmission are not distinctly separate modes anymore, and that transmission in the air is now understood to apply to a continuum of particle sizes, from large droplets to smaller particles that dry and remain airborne for hours. Transmission via aerosols, so that is suspensions of liquid or solid in the air, spans also from droplet to airborne modes. And so the IPC guidelines describe typical scenarios for each mode of transmission, and we do provide examples because it is very confusing. So the guidelines also strongly recommend that a practice appoint an infection prevention and control coordinator, and note that having an IPC coordinator is a requirement of accreditation. You'll see on the screen here that this is not a complete list, but a sort of a description of some of the roles that the IPC coordinator may undertake. Now, it is a big role, okay? And we know that predominantly these sorts of things end up sitting with the nurse or a clinician in the clinics. And so, you really need to think about how do you implement this into your clinics. In saying that, there's no reason why you couldn't share the role. In saying that, you need to make sure that you've got great communication, because I would say that, whoever is doing this role needs to be motivated and willing to accept the position. And subsequently, they need to be adequately educated, trained, and competent to undertake the role and its associated responsibilities. You need to ensure that the nominated staff member is provided with any technical training necessary to attain and maintain competencies. And there's, some competencies that we would consider doing annually, but there's certainly things like hand hygiene that we recommend that gets done every 3 months, because people become very complacent. Okay. So I mentioned training and qualifications. So while currently some states in Australia may have requirements for practicing as an IPC professional, there is currently no minimum standardised educational requirement to practice as an IPC professional or to coordinate your organisation's IPC program. Now, there is a range of postgraduate education programs available for nurses seeking to establish a career in IPC in Australia, although the content of the courses is variable, and I mean significantly variable. And the courses include things from like a graduate certificate to a master's level degree in IPC. Now, when I commenced managing the IPC helpline and the audits of the general practice respiratory clinics and the priority primary care centres, or the urgent care, so the CAP 4-5 general practices, and doing those audits, even though I've been doing IPC for way too many years to mention, I certainly had that imposter syndrome. So I went off and I did my postgrad in IPC through Griffith University. Now, although they tried really, really hard to recognise my primary care background, they struggled, okay, because predominantly, traditionally, where we've seen IPC coordinators are in acute care. And so is it worthwhile you go and doing a postgrad? My comment would be, unless you want to be going on and doing research, because there's a research module in there, and unless you're going to go into acute care and do this, probably not. In fact, the course that I would recommend is the second dot point there, which is the Australasian College for Infection Prevention and Control. They're the peak body for IPC professionals in Australia, and they recommend that healthcare workers apply for credentialing in IPC. Now, in saying that, it's a self-regulated process to determine and acknowledge that an individual has demonstrated the prescribed competence of the relevant specialist role. The program is a short course online. It is a great course. They also have a great network that you can join and a newsletter. Now, again, some of that is a lot hospital based, but the national conference or the Australasian conference this year is in Adelaide, and I pushed really, really hard and managed to get myself onto the organising committee for that conference. And I'm pleased to say, for the first time ever, every day of the conference has a component of primary healthcare IPC this year. So it's really exciting because this is core to everything we do now in primary care. And so we need to make sure that we've got the education and training to support that. Now, whilst I've said that there's no minimum standardised educational requirement, the difference to this part is under section 10, which is the reprocessing of reusable medical devices. And that actually states that practices must ensure that staff involved in reprocessing have received the adequate education, training, and regular competency assessment, and that these are well documented. And again, while there's recommended qualifications for reprocessing, there's actually no minimum requirement, which is again challenging for primary care. However, it is essential that staff responsible for reprocessing reusable equipment completely understand the tasks, know exactly how to perform all steps, and have immediate access to clear and comprehensive instructions. They can be relied upon and then make sure that they are being followed completely. And so the responsibility for reprocessing tasks must not be delegated to admin staff or other staff without first providing adequate initial and ongoing training. And what I will do is at the end of the session, I'm going to pop a resource sheet in the chat, and you'll see there that there is the list of some courses that are available in that space. So section 2 is all about hand hygiene. And so while we know that the use of an alcohol-based hand rub is now recommended for routine hand hygiene for dry, visibly clean hands, except after using the bathroom, before handling or eating food or drink, that one's often missed, or when norovirus or C. diff is present or suspected, an antimicrobial soap would be recommended in these instances. And so as an organisation, you must have hand hygiene facilities readily available to patients and staff and installed in or near all patient management areas, including treatment areas and consulting rooms. You must have the correct selection of hand hygiene products to achieve adequate cleaning and disinfection, and you must educate staff on effective hand hygiene and hand care. right? So it's not just your use of products, it's also around that hand aftercare. So keep that in mind. Hand hygiene facilities, so your alcohol-based hand rub dispensers or sinks, must be provided in all examination and treatment areas and in or close to toilets. Alcohol-based hand rubs should be provided in disposable cartridges with disposable nozzles designed for hands-free dispensing when possible. Refillable dispensers must not be used. An alcohol-based hand rub should not be placed near a sink, but at point of care and other work areas such as your workstations in your reprocessing area. And when building a new premises or upgrading your existing premises, consider installing hand-free or elbow-operated taps for hand washing. And paper towel dispensers must be installed at all sinks. Remember, even when you're working off-site, you must have your alcohol-based hand rub. So in addition to the details on facilities required, the IPC guidelines also outline when hands must be cleansed, following the World Health Organization's 5 moments of hand hygiene, methods and products, including a summary of technique, duration, and drying. And remember, it's 20 to 30 wet seconds to do your alcohol-based hand rub, making sure that, you're covering all areas. And it also covers the hand hygiene requirements for patients. And you can see here, there's a couple of examples of that from the guidelines on the slide. Section 3, we talk around, and just back to hand hygiene, actually, I think I mentioned up front, this is something that we suggest to do every 3 months. It does not have to be the full on, everyone's doing the World Health Organization online modules. That's an annual thing. But doing that practical session, making sure that people are, doing it correctly, we see so much complacency. And so it's worthwhile just having, a spotter, someone that takes that responsibility and making sure it's done. So section 3, PPE. This includes gloves, fluid impermeable aprons, gowns, masks, purpose-designed protective gloves, goggles, and face shields. When we talk around the appropriate PPE in any clinical situation, depends on the risk assessment and the type of clinical procedure or activity being conducted. PPE must be applied and removed in the correct order to prevent transmission of infection. And again, this is another area where we see breaches occur, particularly is that doffing of PPE. PPE is designed for single use, for example, to be worn during a consultation with one patient or during a single procedure, and then disposed of. And that is your gloves, your mask, your face shields, or appropriately laundered if we've got reusable gowns. Hopefully you're not using them. However, such items of PPE are sometimes worn for longer periods in special circumstances, such as like we did during the pandemic. But the guidelines are very specific on this, and it outlines the general principles of PPE use and includes a table of recommended use and the characteristics of the PPE, details of when PPE should be used and how to apply, remove, and dispose of it, and discusses when and why extended use may be appropriate. Remembering here that your N95P2 masks, you should be fit testing every 12 months, or if an individual has a change to the shape of their face. So that might be something like weight loss. You cannot get a proper seal on someone who has facial hair. It is impossible. And so those sorts of things, you should be, people should be doing their fit testing if any of those occur. Fit checking is every time we put on an N95 or a P2 mask. As we're flying through, section 4 of the guidelines addresses the aseptic technique. And so all staff involved in procedures must be familiar with standard aseptic technique and know when to apply it. And so the guidelines talk through the principles and terminology surrounding aseptic techniques, as well as the steps for both standard and surgical aseptic technique. And again, this is another area that can be challenging in general practice. We also talk about the application and agents used to gain skin asepsis. and there's a great poster there. Now, if you are downloading posters, please make sure you're laminating them so that they can in fact be cleaned. Section 5 of the guidelines, we talk around levels of protection, and this is referring to the blood and body substances of all patients must be considered infectious at all times and must be managed as though infectious. So standard precautions must be used by all staff involved in patient care or who may have contact with blood or other body substances, secretions and excretions, including through contact with mucous membranes and non-intact skin, regardless of the known or perceived infection status of that patient. Practices need to use transmission-based precautions in addition to standard precautions when a patient is known or suspected to be infected or colonized with microorganisms that cannot be contained or by standard precautions alone. So that might be something like microorganisms that are causing gastroenteritis, measles, influenza, COVID, etc. It is essential that standard precautions are applied at all times because staff or patients may be at risk of infection from others who carry infectious agents. They may be infectious while asymptomatic, undiagnosed, or before lab tests are confirmed, and we've seen that a lot in the last few years. They may be at risk from infectious agents present in the surrounding environment, including surfaces, objects, or equipment. And hopefully you've got no fomites around your clinics or office-based practice. So, books and toys and just things hanging around. We don't want that. We want as minimal amount in our office-based practice as possible. And we need to perform specific procedures or tasks that are associated with an increased risk of microorganism transmission. We talk here too around respiratory hygiene and cough sneeze etiquette, and this must be always applied as part of your standard precautions. Covering sneezes and coughs reduces air dispersal of respiratory particles that could contain pathogenic bacteria or viruses. Hand hygiene must be performed after coughing, sneezing, or using using tissues, or after contact with respiratory secretions or objects that could be contaminated by these secretions. So that's things like, your face masks, for instance. Patients requesting a consult with respiratory symptoms should be triaged by a health professional via phone or video conference to determine whether or not the consult should be via telehealth or in person. And we know patients are starting to tell us fibs, aren't they, in regards to, what their symptoms are. And that's because they want to get back to being seen in person. That's okay. There's ways to still see those patients. We could be seeing them in their cars. We could be seeing them at the end of the day and clustering, patients with respiratory conditions. So there's a number of different ways we can manage that. We just need to make sure that that process is in place. And all patients with symptoms of respiratory infection must be encouraged to wear a mask inside your clinic, even now, and if able, be seen outdoors to reduce risk on patients, other patients and staff. And the IPC guidelines provide strategies for managing patient access and patient workflows. So have a look at that because, this is a really critical area that we're starting to see a lot of people start to have breaches in because, of the blasé. The guidelines also detail and provide strategies for aerosol generating procedures and for managing contact, droplet or airborne precautions. In relation to preventing staff and patients with relevant infections from entering the practice, the guidelines suggest practices develop and implement a protocol to elicit self-reporting by staff and patients of any symptoms that could be due to an infectious disease. So that might be, like we've already mentioned, respiratory illnesses, gastrointestinal symptoms, or it might be a rash. And so before they enter the practice, we want to make sure we know this. And so strategies include routine questioning by your reception staff when booking appointments by phone, a phone on hold recording message, question or instructions added to your online booking system. And most of these have these now. You may also place notices on your practice website or the main door before people enter. And these communications must explain that the information is necessary to keep staff and other patients safe and reassure patients that they will be given a consult even if they report such symptoms. Oops, don't go too far ahead, Sarah. The other thing that we talk around here, and this one's always a bone of contention, and face-to-face, I would ask you who's doing Spiro now. But practices must identify and follow the latest advice on infection prevention and control when performing aerosol generating procedures. And that includes nebulization, Spiro, peak expiratory flows, oxygen supplementation via nasal cannulas or masks. And there is, significant guidance around this from both national and state or territory health departments, as well as guidelines published by the Australian New Zealand Society for Respiratory Science and the Thoracic Society of Australia and New Zealand. Now, the current recommendation or the guidelines here are that you have 12 air exchanges per hour in the room that you are conducting any aerosol generating procedure. You also need to make sure that the person or the clinician that's conducting it is in full PPE. So that includes an N95 or P2 mask, and that they are then, dotting and doffing appropriately. We also have nothing in that room to make sure that, other than the equipment we're using, to make sure that, if there is any aerosol dispersion, that, we're not having to clean absolutely everything in the room, because we've got so many fomites in there. And we'll go through this a little bit more. I've actually got a chart for you at the end that shows you that depending on your air exchanges per hour, so that is the amount of times per hour that the complete volume of the air in that room is expelled and replaced by fresh air, okay? It is a building standard, and the current standard is a minimum of 6 to 8 air exchanges per hour. Now, a lot of clinics know their air exchanges, and so, there's a piece of homework to go and try and find out, because when you see the chart at the end, if you do have an isolation room or you are having infectious patients in your clinic, you need to follow these guidelines. So Section 6 of the guidelines addresses staff screening, immunisation and management. And so the standards for general practice require practices to encourage staff to obtain immunisations. And in Section 6, staff screening, immunisation and management, we provide additional supporting details for practices to manage that. And you can see indicator C3.5b is shown on the slide here. And what that outlines is that practice owners are responsible for advising staff of the risks of infection and ensuring that staff are aware they are expected to be covered for vaccine preventable diseases to which they may be exposed. So practices can offer staff the opportunity to be vaccinated at work or use their preferred general practice or immunisation service. And practices must maintain up-to-date records of staff immunisation status. Practices must ensure that all staff are aware that they must inform the IPC coordinator, practice manager or employer if they have a known or suspected infectious disease that could be transmitted in the workplace, and that they are not to come to work until they are considered no longer infectious. And for some of you, you might have seen the timeout posters that, we've used for years in childcare. They are fantastic. The next slide, I'll show you something that's very similar to that, that is in the guidelines. And if they have a notifiable disease, they must not come to work until they've completed the required isolation period or met testing requirements following your health department's advice. Practices can implement recommended exclusion periods for those with known or suspected infectious diseases as well. And the IPC coordinator must stay up to date with the health department requirements for notifiable diseases. That is, again, different in every state and territory and even regions. So you need to look at locally, what's the requirement. The guidelines describe principles for managing staff immune status, screening and immunisation policies and procedures. And there is a section, there's a template in Section 6 for staff immunisation records. Now, bearing in mind, we're getting a little bit of pushback in this space currently, particularly around the recommendations for a COVID vaccine. And so we talk now around boosters as opposed to doses, just remember that. But if it's been 6 months or more since the last dose, or six months or more since a confirmed diagnosis of COVID-19, so that's either on PCR or RAT, then the recommendation is that health staff actually receive another vaccine. If you've got staff that are refusing that, you can make it your policy that all staff must be vaccinated, because this is a HR responsibility. As you know, you're required to protect your staff. In saying that, if you've got staff that are refusing vaccination, you need to make sure you've got that documented. You also then need to have a process in place that if you were to have an outbreak in your clinic, bearing in mind that most of these respiratory sites are shut or about to close. And so, we're doing all of that testing in the clinics these days. And so we need to make sure that we can, manage that. In the guidelines, we also outline key recommendations from the Australian Immunisation Handbook on vaccines relevant to general practice, and a summary of the exclusion periods, like I said, for infectious diseases relevant to office-based practice. And as I've already said, you should implement those recommended exclusion periods for those with a known or suspected infectious disease. And your coordinator must stay up to date with your health department's requirements on those diseases. So you can see there's a lot of environmental scanning that gets done by your IPC coordinator. Section 7 talks around SHARPS management, and there's 4 national standards from which the SHARPS section of the IPC guidelines has drawn information. And we've literally consolidated it down to specifically what is relevant in general practice. And so there's clear protocols for safe handling, use and disposal of SHARPS that's necessary to prevent injury that could lead to an infection. And all staff who come into contact with SHARPS need education about the safe use and disposal of SHARPS. And the IPC coordinator can educate, train and lead the team to practicing safe SHARP management consistently. The standards require that members of the practice team manage risks of potential cross-infection by methods that include safe storage and disposal of clinical waste, and that includes your SHARPS. Okay. The guidelines also recommend the use of safety engineered medical devices in primary care wherever possible, so that practices may reduce the risk of SHARPS injuries through the use of these safety engineered medical devices and other technologies that will significantly reduce risk of SHARPS injuries. And you can see on the screen there, we've listed a number of, the types of things that you can use. Now, in saying that, some of these aren't cheap. And so it's not something that you may implement overnight. But as you start to replace equipment and etc., think about, how you can start using some of these things. The guidelines also have a summary table outlining the essential do's and don'ts of safe SHARP management. And so that's a great one to print off and laminate and stick up, because we know that whoever generates the SHARP, it's their responsibility to dispose of it. But how often do you find SHARPs sitting around, after procedures and things like that? So have a look at those, and, think about how do you include this in your staff meetings. You should always have IPC as a line item in every staff meeting, and you can take different parts of the guidelines and share them, to use that as some education and training. Section 8 of the guidelines addresses exposure to blood and other body substances. And so this is where we talk around all staff must be aware of how to prevent exposure to blood and body substances. And any blood or other body substance to which a staff member is exposed must be managed as a potential source of a blood-borne viral infection. And regardless of the individual's diagnosis or perceived risk, we automatically assume that they're infectious until proven otherwise. So all staff need to know what to do if they or someone else, because it may actually be a patient that is exposed to a blood or body substance, including who to report the incident to and what immediate actions must be taken. Okay. So management of an occupational exposure involves first aid, including immediate decontamination of the exposed area, risk assessment and rapid testing of the exposed person and the source person for bloodborne viruses. Prompt post-exposure prophylaxis may be indicated, and we need full documentation of the incident to enable investigation, counselling of the exposed person and the source person, and analysis of the cause of the exposure incident, and modification of procedures as required to reduce the risk and reoccurrence. And the biggest one there is our staff education. And so in section 8 of the guidelines, we explore these steps in more details and give practices practical details for the management of each of these steps. Some of the steps might be done or must be done, in fact, if you think about it, the first few within your organisation. And these includes things like those decontamination, the documentation, analysis and risk reduction, as well as your staff education. So allocation of responsibilities for each step depends on the individual's practices, policies. And so as an organisation, you may choose to refer to external providers. So you might have an occupational health physician or the hospital emergency department nearby, and they may do your risk assessment, your bloodborne virus testing and your post-exposure prophylaxis if required. But these must occur within several hours of the exposure, remembering that. And the other big one is that counselling, okay? And it's not necessarily just the immediate counselling. I don't know if anyone's ever had an exposure, but that period, up to 6 months when you're waiting can be horrid. So just, make sure you're thinking about that longevity. It's not just the immediate situation. And so as an organisation, you must follow requirements for reporting Sharps injuries and exposure to blood and other body substances according to legislation in your state and territory. You must have written policies and procedures to manage accidental exposure to blood and body substances, whether it be by penetrative injury or splash to eyes, mucous membranes or broken skin. And the policies should be relevant to the daily routines of your practice and must be reviewed and updated regularly. When we talk regularly, you would say at a minimum 12 monthly, but if you have an incident, you would definitely review your policy at that point. And so in the event of an exposure incident, all staff must know what to do immediately after the exposure, who is responsible for ensuring that necessary activities are carried out, and who to report it to. So that includes your non-clinical staff, remember. And staff must have immediate access to contact details of the nearest emergency department, including the location, the nominated external service provider to whom you refer to, and the health authority to which they must report the exposure if required. Employers must ensure that staff receive regular training and education appropriate to the tasks they are being expected to perform. And staff involved in exposure-prone procedures must have access to the appropriate information, training, counselling and vaccination programs. It is mandatory to report occupational exposures immediately to the designated person, if present, for advice and further treatment, if indicated and available. All testing procedures and follow-up treatments must be fully documented, and organisations must follow their state or territory requirements, as we've said, for reporting Sharps injuries and exposures to blood and other body substances. You can probably hear in this section there is a lot of musts, okay? And, that's obvious because the risk here is significant. So if the incident occurs during a procedure, the possibility of the patient being exposed to the injured health professional's blood must also be considered. And if there is risk that a patient was exposed to a health professional's blood, the guidance on risk assessment, screening tests and treatment of the exposed person must be applied to the patient. And then after the exposure incident has occurred and been managed, the employer must analyse the cause and modify procedures as required to reduce the risk of reoccurrence and to protect staff and patients. And healthcare workers have a responsibility to know whether they have a bloodborne infection. So organisations can encourage self-disclosure by ensuring confidentiality, and where practical, by providing counselling and modification of work practices or redeployment to reduce risk of transmission if necessary. And health workers with bloodborne infections should be advised by their treating clinician about any limitations to exposure-prone procedures they can perform. And again, that should be, communicated to the employer. How are we feeling? We're flying through. We're going to have lots of time for questions. So Section 9 of the guidelines addresses cleaning, laundry and waste management. And so there are 3 national standards from which this section draws information, consolidating to what is relevant again to office-based practice. And these relate primarily to the management of clinical and related waste and laundry practice. Hopefully, if you are still laundering your own linen, you are following the guidelines. Because if you're not, you're at risk. Practices must have a current cleaning policy that identifies staff members' responsibilities, work health and safety issues, and procedures for routine scheduled cleaning, unscheduled cleaning, and monitoring of effectiveness. Practice must perform a risk analysis to determine the methods, frequency, and thoroughness of cleaning and the products to be used. We need to avoid reusable linen where possible through the use of single-use paper sheets on examination tables and single-use disposable surgical drapes, disposable sterile barrier systems from surgical packs, things like disposable curtains. All staff, including those without primary responsibility for cleaning, laundry or waste management, must understand and follow policies for cleaning and hygiene throughout your organisation. This includes any external cleaners that you may contract. They must understand your IPC policy for cleaning and if they're doing laundry and disposing of any waste. And so you should also not have cleaners bringing in vacuums from other sites. You should have your own vacuum with a HEPA filter, mops, etc., that are used only for your clinics. The IPC guidelines include details on what to include in a practice cleaning policy, examples of items in the practice cleaning schedule and accompanying a template, details of the section and use of selection and use of disinfectant and detergents. And you know what? The best one are our 2-in-1 wipes because they disinfect, or they clean and they disinfect. It also gives you details on cleaning spills, including contents of a spill kit. You don't have to buy the expensive pre-made ones. You can make them up. And details on cleaning after contamination by a blood or other body substance, including a sample spills cleaning protocol and an accompanying template. You can see you don't need to reinvent anything at all here. Practice must have an up-to-date policy for waste management that conforms to state and territory regulations and meets the current national standard for management of clinical and related waste. Waste must be safely and appropriately segregated into clinical waste and general waste as it is generated. And staff responsible for handling waste must receive regular, updated education and training on safe handling and disposal. That also includes where you're storing that waste in a locked, safe area. So in relation to waste management, the guidelines detail work health and safety considerations, waste segregation, clinical waste containers, general waste containers, storage of waste, and the collection and disposal of waste. There is a national standard of its own. It is not cheap to buy. It is behind a locked paywall. But, if you are doing your own cleaning or your own linen or anything like that, please download that standard to make sure that you're following it. No one should be cleaning their own linen anymore. And as I said, you should be using disposable curtains. They can stay up for a year unless visibly soiled. And so, you just write the date on them when they go up. And when you consider the cost, if you're meeting the standard for laundering, you'll find that it's actually much cheaper to go to disposable. Yeah. Here's the big one. And this one always always creates angst. So Section 10 of the guidelines addresses reprocessing reusable medical devices. And so this section is primarily based on the requirements that are set out in the AS/NZS 4815. You'd think I'd know that number off by heart now. Office-based healthcare facilities not involved in complex patient procedures and processes. So that's the cleaning, disinfecting and sterilising of reusable medical and surgical instruments and equipment and maintenance of the associated environment. And NZS 4187. And that's the reprocessing of reusable medical devices in health service organisations. Now, these two standards are so outdated, it's not funny. And they're currently under review and will be superseded by the new standard AS 5369. This standard started development in 2021, and we are expecting it's imminent. We have a copy of the final draft for review and comment. That's been closed for a couple of months now, but this is going to bring about some huge changes in office-based practice. And so this standard will be known as the reprocessing of reusable medical devices and other devices in health and non-health related facilities. And Standards Australia has advised that there is no confirmed timeline for its release, but they have indicated that it is likely to occur in the latter part of this year. So as Section 10 is based on these existing standards, there is absolutely no current changes to practice requirements for reprocessing. The guidance will be updated after the new standard has come into effect. Now, whenever a new standard, as in a national standard, so an Australian or New Zealand standard, is released, generally speaking, we have 12 months to implement that standard. So it's not that if it comes out tomorrow, you've got to start and change everything, but certainly we will need to work towards that. So let's unpack this a little bit, because this is where we know that practices are not meeting the requirements. So reusable medical devices that require reprocessing to achieve the required level of asepsis, including surgical instruments, medical devices, and other equipment, sit here. You can choose to reduce the volume of medical devices that require reprocessing by replacing some or most categories with disposable alternatives. Practices that reuse medical devices that require sterilisation, such as surgical instruments, can choose either to do all reprocessing on site or outsource to an off-site provider. Reprocessing of items that require sterilisation should only occur within the practice if the current relevant standard can be met. So for each reusable medical device, practices need to check information provided by the manufacturer on the validated process for cleaning, disinfection, packing, if required, and sterilisation. And so you'll see we talk around reprocessing, not sterilisation. Sterilisation is probably the smallest part of the reprocessing cycle. So organisations should have a designated area for processing reusable medical devices that must establish a workflow pattern that prevents the packing, sterilisation, and storage areas from becoming contaminated. This involves systematically moving from dirty to clean within the designated area, and the reprocessing area must be separate from the treatment and administration areas. So the IPC guidelines include a sample design and workflow of a reprocessing area, and we do have on there, and I'll show you in a moment, some potential variations to that, but this is what reflects best practice. And we know that we all have to move towards this. So PPE equipment must be worn during reprocessing and may require changing between stages. So immediately after use, reusable medical devices should be initially wiped or rinsed to remove any visible soiling, then thoroughly cleaned in the equipment reprocessing area before sterilisation. This process can involve manual cleaning, the use of an ultrasonic cleaner followed by a manual cleaning, or the use of a washer disinfector that may incorporate an ultrasonic cycle. Ultrasonic cleaners and washer disinfectors require performance monitoring and validation as well. Now, it has been leaked that potentially this is a huge area that is going to change for us when the new standards release. And that is, it's suggested that we may all have to have a washer disinfector. Now, I don't know about you, and if you've looked them up, but they're definitely not cheap, right? They start with probably 4 zeros and a 1 or a 2 in front of it. Yeah, so they're definitely not cheap. The steam under pressure, we know, is the most reliable method for sterilising cleaned, reusable medical devices and is recommended in general practices and other office-based practices. If an item cannot be cleaned, and this is the critical bit, I tell you, the amount of green-handled scissors that I've seen reprocessed when they're single use is scary. But if an item cannot be cleaned, it cannot be further processed or reused. And that is the critical component. So reusable medical devices that require reprocessing to achieve the required level of asepsis include surgical instruments, medical devices, and other equipment. And so when you think about all of this, just know that, think about the equipment you've got. There's a lot, in your organisation. Would you be better off if you've got things that you're storing for 12 months, once they've been sterilised, replacing those items with single-use items? Or do you even need them at all? Or if it's something you do once a year, can you not reprocess them? Keep them clean in a container and reprocess them or sterilise them the day before you need them. So the IPC guidelines further details the correct sterile barrier system that you need to implement, preparing, loading, running, and unloading a sterilizer, and documenting cycles. We talk through storing sterilised, reusable medical equipment. We talk about record keeping and maintenance, tracking reusable medical devices for patient tracking, bearing in mind you must be able to track every single load from your sterilizer to your patients. So hopefully you have a log, whether electronic or paper-based, that when you use an item, you then put the patient's name next to it and the date used. Because if you have to recall patients from a complete batch, you need that log, and it's a requirement for accreditation. You cannot search a patient's record where you have entered the batch number or the load number of the item that you've used. We talked through also using off-site sterilisation services and reusable medical devices that may be online. And that really is making sure that you've got those agreements in place. So here's an example of a sterilisation or a reprocessing flow in a small office facility. And you can see here that on this occasion, we've got a couple of options. You may have to have your in-out in the same door, but ultimately we want an in one way and an out. We go from dirty to clean. Our airflow, in saying that, goes from the clean zone to the dirty zone, so the opposite direction. So we come in, we deliver, we wash our instruments, etc. We might have an ultrasonic cleaner. If not, that's fine. We then have our rinsing sink. You'll see that we've prepared this for what's coming, but have a single-ended washer disinfector. If not, we then inspect and dry, etc. We pack and we put them through the load. You should not be leaving sterilised items in a steriliser overnight. When that steriliser goes off, you remove them, you inspect them, and you store them immediately. And then ultimately, we want to be going straight out. Obviously, we have our hand washing facilities here and here. And like I said, our ventilation is going clean to dirty, whereas our process is going dirty to clean. Yeah. Alrighty, section 11. We're so close and we're going to get there, so we've got time for questions. So section 11 of the guidelines addresses disease surveillance and outbreak response. And staff should be familiar with their statutory requirements for monitoring and reporting disease outbreaks or other infection prevention and control incidences to the relevant state and territory authorities. You must develop procedures to ensure that notifiable diseases are promptly reported, and all staff members must receive education to minimise the risk of infection transmission when patients present with suspected or confirmed infectious diseases, including how to apply transmission-based precautions. An IPC kit containing items that for implementation of standard and transmission-based precautions, including PPE equipment, could be available at reception to be used when a patient presents with a suspected or confirmed infectious disease. And your admin staff must receive education and training on when and how to use these kits correctly. General practices or other office and community-based practices must have systems in place that allow for monitoring of threats and outbreaks. And any emerging diseases, such as with, COVID-19, an avian flu, or a multi-drug resistant organism. We must ensure that the practice remains up to date with information. It is useful to nominate a staff member to take responsibility for receiving and acting on notifications from both federal, state, or territory health departments about any emerging infectious diseases, as well as regularly checking the websites of the relevant public health authorities for guidelines and disseminating any updated information to other staff. Again, it's a perfect opportunity to use, your staff meetings to include this in. So the person responsible for maintaining up-to-date information on IPC preferably should be a full-time staff member, and they should be handing over this role during any absences. They must also maintain their knowledge and skills through continual professional development courses offered by the states or territory health departments and other organisations. General practice and other office and community-based practices need a system in place. To ensure prompt reporting. So some notifiable diseases require notification by phone, so just keep that in mind. But the guidelines link to the relevant jurisdictions and their notification policies. And we further detail in the guidelines practices responses to threats, patient-specific precautions, and IPC kits for your reception staff. The big last one, section 12. So in section 12, we talk around addressing planning of a practice, the design, the fit out, and the equipment and consumables that you need to consider. IPC is an essential consideration when planning and designing a new practice or renovating a practice building, if that's what you're doing. No longer do we want windows that are nailed closed. We don't want that at all. The best ventilation is open windows and open doors. So when planning ongoing maintenance, it's really critical to think about, your site and the equipment that you might be using. So aspects of building design and organisation that affect IPC include your choice of surface materials for not only your walls, but your floors, your desks, examination and treatment tables, for instance, the material and design of fixtures and fittings, the provision of areas that can be used for isolation or an isolation room to ensure adequate ventilation, the design of the reprocessing area and your storage area, your waste management areas, and placement and design of hand hygiene equipment. These are all sorts of things that you need to consider. Aspects of equipment setup that affect infection prevention and control include your choices of disposable versus reusable medical devices and your choice of information technology hardware and phones. And this includes, the ease of cleaning keyboards or handsets or other devices that you might be using in your sites. We need to ensure that ongoing maintenance of the building and equipment should be carried out as necessary to minimise infection risk. So you can see there people say, how often should we be cleaning daily now? Well, that depends on the environment, your cohort, and the risk. And so you need to do that risk assessment. That is the key word across all of this, is we risk assess everything. So your IPC coordinator should be involved in your purchasing decisions about consumables, equipment, PPE, hand hygiene agents, manual or automated cleaning, disinfecting and sterilising systems, your furnishings, your reusable medical devices, your single-use and single patient use devices, and that includes sharps, chemicals used for environmental cleaning, for instance, and disinfection, your waste management systems, and any other relevant clinical purchases. Huge role, right? So let's have a little chat quickly about ventilation, because this is something that really has come about. Well, it hasn't come about since COVID. It existed significantly, a significant amount of time before that. But we know that practices really haven't got up to speed on it. So adequate ventilation, whether achieved by natural airflow or air conditioning, is necessary to reduce the risk of airborne transmission of microbial infections in enclosed indoor environments. Practices could consult a ventilation engineer or an occupational hygienist for advice on optimal ventilation when designing the space, refitting the space, or during an airborne transmitted outbreak. Ventilation in your sites must be designed to achieve the 6 to 8 minimum changes per hour. And that, as I said, is the number of times per hour that the whole volume of air in each room is replaced by fresh air. And that's in all of your general areas. Fresh air is preferable over reticulated air, and flows less than 6 changes per hour are inadequate to help prevent airborne microbial transmission. And so in rooms, like I've said, where you're doing aerosol generating procedures like Spiro, a ventilation rate of 12 air exchanges per hour is recommended. So the direction of the airflow must be from clean to less clean areas to avoid dispersing contaminated air. And standard heating, ventilation, and air conditioning systems are not specifically designed to prevent transmission of airborne infections, but they can be used to optimize ventilation to assist in the reduction of risk of transmission. And so some contain high efficiency particle air filters, or HEPA filters, as you'll know of them, which require regular cleaning and replacement. And your heating, ventilation, and air conditioning systems must be well maintained and regularly serviced. Unless the practice has adequate natural ventilation that consistently achieves adequate cross flow of air, air conditioning must be run to ventilate the area to achieve that 6 to 8 changes per hour, even when heating and cooling are not needed. So you'll see there that you must always have, right, ventilation happening. So windows and doors can be opened for additional ventilation when there is a high risk of airborne transmission, although it does not guarantee adequate airflow. It actually just contributes to it. Fans can be used to improve airflow, and practices can obtain advice on whether the air conditioning system can be used at the same time. And so if you think about things like air purifiers, etc., they're what we use, or air cleaners. They don't provide ventilation, but what they do is help to clean the air. And so portable air conditioning devices with HEPA filtration can be used in addition to other ventilation in areas where an adequate fresh air flow or circulation exists. The clean air delivery rate must be sufficient for the room volume. So you need to know your room volume. And before considering buying air purifiers, I would obtain advice from an expert, like an industry or occupational hygienist or a heating, ventilation, and air conditioning professional. Be careful though, because there is some out there that are rorting the system. And really what we want to know from them is whether or not it's likely to improve ventilation significantly if you consider purchasing these items, and to determine the most effective placement because generally we put these sorts of devices where there is less air movement, okay? Also remember that toilets must be fitted with exhaust fans, and where there's a risk of airborne transmission of relevant infections, so for instance, during respiratory infection outbreaks, your organisation could ensure that exhaust fans in the toilets are ensure that they're functional, operating continuously and at full capacity when the building's occupied. And toilet fans should exhaust directly outdoors and away from windows or other intake systems. Toilets can be fitted with a second passive fan on the external wall, which moves fresh air into the toilet area, while the active air fan then removes the used air out. And these are located sufficiently apart so that fresh air is not immediately exhausted. So in section 12 of the guidelines, that includes further details on, like I said, building design and the fit out in addition to ventilation requirements. It also outlines for you considerations from purchasing consumables and your reusable devices and notes on common single-use items in primary care. So the last slide I have for you tonight in regards to information is the one around air exchanges and the time required for airborne contaminated removal to be efficient. And so you'll see there on the screen, I spoke about 12 air exchanges. We also always aim for a 99.9% efficiency, okay? So if you've got 12 air exchanges in your room, and we're going for a 99.9% efficiency, you need to leave that room closed up after doing any airborne generating procedures or having an infectious patient in that room for 35 minutes before a staff member then goes in the appropriate full PPE to actually clean that room. If, however, you're only operating, for instance, at your 6 air exchanges per hour, we're looking at 69 minutes that you cannot use that room for before it's then cleaned and then can be used again. And you need to make sure you've got your processes in place to ensure, right, that that room is not accessed during those times. So I will share the link to this document with you in just a moment so that you do have that. But you can see why it's really important to have those higher air exchanges. It's 7:22. I can't believe it. It's so different when you're not in a room. IPC guidelines, there they are. I'm going to pop a document into the chat now. Hopefully it will let me do that. And this document will give you some key links on all the things I've spoken about tonight. Does not want to work for me. Let's have a look. And yeah, so it'll give you all those resources that I've spoken about. Cindy's put, I still don't understand what it means to have 12 air exchanges per hour, e.g. on how we achieve this. You have to actually get, like I said, Cindy, it's not something that you just know. So if we go back to this slide, I mentioned on one of these that you actually need a proper professional to come out and do that. And so that's a hygienist or an air conditioning specialist. And they will come out and they have special machines that they actually measure those air exchanges. And they will tell you what those are. And then once you know what those air exchanges are, you can actually use these tables and the guidelines to actually have a look at what that means. Hopefully that's helped answer that question. I just want to try and get this document work for you. Eloise, I don't know if there's no other questions in the chat.
I couldn't with the QR code. So for everyone, I'll just cap this at the moment. I've just put a evaluation QR code in the chat. So if you guys just wanted to scan that, and that can provide us with feedback on how you thought it's gone, any feedback for future. It's a really good evaluation tool. But Sarah, I had to copy and paste that. So I don't actually think you can put documents on this. But we do have everyone's email address, so we can email that through to everyone's phone.
Yeah. Okay. I will just email it. Yeah, I'm trying to copy and paste it and it's not working.
Yeah, it didn't work for me either. So apologies, but we'll
No,
send
that's
that
all right. I will send it to you and then you've got that.
Perfect. Thank you.
Are there any other questions?
Can't get the QR to scan on my device. Okay, no worries. I'll also attach that in the email tomorrow as well. It's going to be a SurveyMonkey link, so I'll actually attach the link in the email that we'll send through to everyone as well, so you can do that sometime tomorrow over the next few days.
Right, when it works. We also get a copy of the slides. No, the recording is going out, but unfortunately we can't share the slides. But yeah, there will be the recording.
Yes, we'll send that link out to everyone as well. It's going to be a big email. Okay, so Rowena's just put a question. Hi, our building is old and we don't have exhaust fans, but do we need to install them now?
If you're to meet the guidelines, then yes. So I guess my question there would be, again, it's about risk reduction. You've got to do your risk reduction. But if you are going, the one thing we know is all surveyors have different areas of interest. Yeah, that's just the way it is. You know, for some, you know, it's vaccines, for others, it's reprocessing, for, you know, etc. And so you can never tell on the day what you're going to get, right? But you do need to be meeting the standards. And so, you know, that very much is one of the standards. And it is a risk reduction. So, you know, you would need to get someone out to come and have a look at that, and yeah, go from there. What have we got?
Got another one from Nadia.
Difference between an autoclave and a single-ended washer. An autoclave is the old name for a sterilizer. Single-ended washer. I'm not sure what a single-ended washer is. If Nadia wants to, I can't say I've heard of a single-ended washer. But to me, just the two names suggest that they're definitely different. Because one's sterilizing and one would appear to be washing. Happy to take that on notice, but unless you've got a little bit more information, Nadia, I'm not really sure what that is.
Anyone have
we
any
should use
questions?
The fan function on the air conditioners if cool or heat is not needed for the exchange rate. You can, but you need to get like someone out to assess it first. Yeah, for sure. Yeah, make sure that you get that assessment done first, because it's also around the speed of the fan, you know, so that the circulation that it's generating, you know, where you want it going over people's heads, you don't want it blowing on them. Generally, we keep them on low, but it very much depends on what the rate of air exchange is in that room as well. It is so complicated. I don't even claim to understand it all. I just rely on, you know, the specialists and their reports. Their new air conditioners, that's positive. Cindy, thankfully. Oh, sorry, that's Simone. Yeah. Is it a must with air exchangers, Sarah? It is a must. It is a building compliance to have 6 to 8 air exchangers per hour. That standard change, that's a national standard. That standard changed probably 6 or 7 years ago now. And I remember very well when it changed, because the office that I was located in, we had a boardroom and we used to do a lot of training. And being on the Gold Coast in the middle of summer, you guys can relate. you know, all of a sudden you'd get this gush of hot air into the room and everyone would jump up and want to go and turn the air conditioning down, thinking it wasn't coping. And I said something to the office manager one day. She said, oh no, we've actually had to, you know, have our air exchanges updated to meet the requirements of the building standard. And that's way back when, before I even was involved in this stuff. She said to me, and so every hour, 6 to 8 times an hour, the whole content of air in this room is expelled and replaced with fresh air. Well, that fresh air is hot air in the middle of summer. So, of course, it takes a few minutes for the room to cool down again. Now, that's a bit different in a really big room. It's not quite so obvious in smaller rooms. But, yeah, definitely. You do need, that is a building standard, 6 to 8 as the minimum. Do we have to have adequate ventilation to meet standards? Is there a requirement now that this should be met? Yes, definitely. So that's the same one that we've just answered. If filters are used in spirometry, most definitely you still need to be using full PPE. So I have sent to Eloise the guidelines, some resources. Have a look at that, and that will actually talk you through all the requirements that you need. If you can meet all of those requirements, obviously you're reducing your risk significantly. Is there an opportunity for you to do spiros and aerosol generating procedures outdoors? Just remember that best practice, if is using spacers now, not nebulizers. Also, spacers are single patient use. They cannot be reprocessed or sterilized. You should not be having a practice spacer and using it on multiple patients. They are all single patient use. If you do need to do that, then you need to get, you know, the little cardboard ones, the disposable ones. All spacers are single patient use. They cannot be sterilized in your clinic. In fact, the plastic starts to break down. You know, get practices, get patients into the habit of bringing their own spacers in if you need to do that. But yeah, have a think about what you can do outside. Where are we?
Someone had their hand up as well. I think, was it Rhiannon? Sorry, I'm just trying to, it's gone down. So whoever had their hand up, did someone have a question? No, maybe I'm seeing things. It's been a long day.
It has, hasn't it?
My son pressed the button. No worries.
We've all been there, done that.
Yeah.
Yeah.
Sorry about that.
He's joining us now. That's all right. He wants to come to the party.
Yeah, it's been really, really informative, Zara. It's been, yeah, I know that we had a lot of great feedback from the face-to-face ones and some really, really valuable information, especially, you know, I see Cindy's a new PM and we're seeing a lot of PMs, you know, new coming into the role with no experience. So these sorts of things are really, really valuable for those people in those roles.
And look, it can be really overwhelming. The one message I would say to you tonight is don't think you can implement all this overnight, right? Have a look at the low-hanging fruit in your clinics. What are some of the things that you can implement that will actually just start to reduce risk for you? It might be reviewing your policy and procedure manual. It might be making sure that, you know, you haven't got fabric chairs in your clinics or in your practices. You know, it might be doing things like having that PPE kit sitting at your front desk. You know, it might be reviewing all your immunisation records, because obviously we should be having influenza annually. And so we often see that those records aren't getting updated to reflect the current recommendations. You know, just think about what are some of those easy wins and actually start to implement them. You cannot do this all at once. Let me tell you, the general practice I work in, we don't have all this in place. And I'm there, right? So it's a work in progress. Yeah. But if you're doing your best, you know, and you're always trying to do that quality improvement, and it's on the radar, then, you know, you're going to continually improve, which is great. So have a think about, you know, what is the low-hanging fruit and how do we actually start to just implement some of that? Any other questions?
Running a little bit ahead of time, which is great.
Yeah.
If no one has any more questions, we might wrap it up. As I mentioned, we will be sending out all of those materials. It'll come from my colleagues, either Deb or Chloe. I'm on annual leave for the rest of the week. So if you do see it come through from them, that's what that is. And they'll send through the link for the Survey Monkey as well. And any evaluation or feedback on tonight is really, really taken greatly and appreciated. And on behalf of NQPHN, I'd really like to thank Sarah for the sessions that she's done with us over the past few weeks. I know you've been a very busy lady going between Townsville, Cairns and Mackay.
I have. It was fun.
Yeah, it's a good time of the year to be up this way as well. It's absolutely beautiful.
Yeah.
So yes, that's been great. And if you have any further questions as well that you think of over the next few days or next week, feel free to email them through to us as well, and we can liaise with Sarah and get some information through.
Definitely. Sounds perfect.
No worries.
Just another little secret. Currently, the IPC Victorian Helpline has a web page on the Atlas site. Have a look at what's there. It's relevant nationally, okay? If there's anything that's state specific, just make sure you check with Queensland. But there's some great tips and tricks and webinars and things there too that you can access. It's not a closed access. So have a look at that.
No worries. All right. Well, thank you, everybody. And I hope you have a great evening and a great rest of your week.